Good evening, everyone. Today we will be dealing with the tumors of salivary glands. I am Sadiq KM of second year MBBS, Crims Karwar. As we delve into this topic, it's important to first recognize the anatomical and physiological context of the salivary glands. These glands play a crucial role in the production of saliva, which is essential for the initial stages of digestion and maintaining oral health. Now, focusing on the tumors themselves, they can occur in any of the major salivary glands, the parotid, submandibular, and sublingual glands. Tumors can be either benign or malignant, with varying degrees of progression and impact. Understanding these tumors requires a multifaceted approach considering factors such as their histological characteristics, clinical presentation, and potential treatment pathways. As we move forward, we will explore the classification of these tumors, starting with benign types like pleomorphic adenoma and Warthin's tumor, and then examining malignant varieties. Each type has unique features and implications for patient care. When discussing the classification of salivary gland tumors, it is essential to understand the distinction between benign and malignant types. First, let's talk about benign tumors. The most common is the pleomorphic adenoma, often referred to as a mixed tumor due to its varied tissue types. Another prevalent benign tumor is the Warthin tumor, known for its cystic nature. Then we have oncocytoma and basal cell adenoma, both of which are less common but still significant. Now, moving on to malignant tumors, the mucoepidermoid carcinoma is the most frequently occurring one. It's crucial for early detection and treatment due to its aggressive nature. Understanding these classifications helps in diagnosing and choosing the appropriate treatment plan for patients. Let's dive deeper into specifics, starting with Warthin's tumor in the next slide. Let's delve into Warthin's tumor, an intriguing subject in salivary gland neoplasms. This tumor is notably the second most common neoplasm found in salivary glands, specifically accounting for about 8% of all parotid gland tumors. It primarily affects individuals between the 4th and 7th decades of life, with a higher prevalence in males than in females. An important risk factor to highlight is smoking, which significantly increases the likelihood of developing this tumor. It is also known as papillary cystadenoma, lymphomatosum, or adenolymphoma. Warthin's tumor presents unique characteristics which we will explore further in the next slide. When discussing the site of Warthin's tumor, it's important to emphasize that it almost exclusively occurs in the parotid gland. This is a key point because it highlights the tumor's specificity in terms of location. The parotid gland is the largest salivary gland located near the ear, which might explain the tumor's tendency to develop there. Understanding this can help us appreciate why early detection and monitoring of parotid gland changes are crucial in managing salivary gland neoplasms. Now we will be dealing with gross features of Warthin's tumor. It's typically encapsulated, meaning it is well defined and separated from surrounding tissues. This encapsulation often results in a round or oval shape with a smooth surface, which is relatively easy to identify during examination. And the characteristics are it has a characteristic slit like or cystic spaces that are commonly found within the tumor. These spaces often contain a milky fluid and are known for having papillary projections. This distinct appearance can help differentiate Warthin's tumor from other types of salivary gland neoplasms. Now let's prepare to delve into the microscopic characteristics of Warthin's tumor, where we will explore its epithelial and lymphoid components. In this slide, we are diving into the microscopic features of the tumor, which is essential for understanding its pathology. Firstly, let's talk about the two key components observed in microscopy. First one is epithelial parenchyma. This refers to the glandular and cystic structures. These structures are notable for their papillary arrangement. This means they have finger-like projection, which is a classic feature we look for under the microscope. Here you can see that. Second one is lymphoid stroma. Underlying the epithelial layer, you will find prominent lymphoid tissue. This is often accompanied by germinal centers, which are indicative of an acute active immune response. Additionally, it's important to note that these structures are lined by a characteristic eosinophilic epithelium. This refers to the pink staining of the cells when observed under a microscope, which helps pathologists identify the tumor type. Here you can see the microscopic features of Warthin's tumor. Now we will be dealing with the clinical features. Firstly, the typical location of the tumor, which is often below and in front of the ear. This is a key identifying feature that can aid in initial assessments and diagnosis. Secondly, these tumors are usually painless. This is an important point because the absence of pain can sometimes delay diagnosis, as patients may not seek immediate medical attention. Lastly, the slow growing nature of these tumors. This characteristic can influence the management and treatment options, as there may be more time to carefully plan the best course of action. This is all about Warthin's tumor. Now we will be dealing with a malignant type of salivary gland neoplasms. Mucoepidermoid carcinoma. It is a significant topic when discussing salivary gland tumors. It's important to highlight that this type of carcinoma is the most common primary malignant tumor of the salivary glands. It accounts for about 15% of all such tumors, making it a crucial area of study in the field of oncology. When we look into the demographics, mucoepidermoid carcinoma does not show a preference for gender, affecting males and females equally. This is an interesting point as it underscores the non-discriminatory nature of this tumor type. Additionally, while mucoepidermoid carcinoma can occur in individuals of any age, it is worth noting that children can also be affected. This fact highlights the importance of awareness and early detection across all age groups. Our understanding of mucoepidermoid carcinoma will deepen as we explore its etiology and genetic factors in the next slide. Exploring the etiology of mucoepidermoid carcinoma. In examining the causes of mucoepidermoid carcinoma, it is crucial to focus on the genetic factors that underpin its progression. The key genetic factors are activation of the Notch pathway. The activation of this pathway is a pivotal event that instigates uncontrolled cell division, which is a hallmark of cancerous growth. Next, it is the balanced chromosomal translocation. It is important to note that the significant translocation between chromosomes 11 and 19, specifically at loci Q21 and P30. This translocation is particularly noteworthy as it results in the formation of a fusion gene. Next is the fusion gene composition. The fusion gene is composed of segments from the CRTC1 and MAML2 genes. This genetic alteration plays a substantial role in the development of mucoepidermoid carcinoma. It is fascinating to consider how these genetic modifications can significantly influence the emergence of tumors. Understanding these mechanisms is essential for the advancement of targeted therapies in the future. Now, this slide focuses on the typical sites of mucoepidermoid carcinoma, highlighting that the parotid glands are the most common location, accounting for 60 to 70% of the cases. It also significantly affects minor salivary gland, indicating its widespread impact. When, when discussing the gross anatomy of mucoepidermoid carcinoma, it is important to paint a clear picture of its physical characteristics. Let's begin by noting the size. These tumors can be quite large, reaching up to 8 centimeters in diameter. While they might appear circumscribed at first glance, it's crucial to highlight that they often lack well defined capsules. This means they can be infiltrative, particularly at the margins, which may affect surrounding tissues. If we look at the cut surface of these tumors, they typically present a pale gray-white appearance. Additionally, they contain some small cysts filled with mucin, which is a key identifier in their gross examination. These characteristics are vital for distinguishing mucoepidermoid carcinoma in a clinical setting, and they will set the stage for understanding its microscopic features, which we will discuss next. Let's delve into the microscopic characteristics of these tumors. The tumor cells can be found organized in a variety of structures, such as cords, sheets, or even cystic formations. This diverse arrangement offers an insight into the complexity of the tumor structure. The composition of the tumor is also quite variable. It primarily consists of three types of cells: squamous cells, which are flat cells typically found on the skin's surface; mucus secreting cells, which produce mucus that helps protect and lubricate surfaces; and the last one is intermediate cells, which are a blend of the other two cell types. These features are essential for understanding the tumor's behavior and potential impact. When discussing the clinical features of this condition, let's focus on the key symptoms that patients might present with. First one is trismus, or the inability to open the mouth fully, can often be an early sign and might point towards issues with the jaw or surrounding areas. Next one is otorrhea or ear discharge, could indicate involvement of the ear canal or middle ear, often resulting from tumor growth or secondary infections. Next is dysphagia or difficulty swallowing, might arise due to obstruction or pressure on the esophagus, which can significantly impact a patient's quality of life. It's important to note that these symptoms are usually painless, although pain may occasionally occur, possibly indicating further complications or tumor invasion into surrounding tissues. Now we have a case scenario. Let's delve into this clinical scenario. We have a 35-year-old female who presents with notable symptoms, fatigue and gum bleeding. Upon examination, we observe gum hypertrophy along with bleeding and splenomegaly. These are the significant findings. Moving on to her laboratory results, the full blood count reveals a hemoglobin concentration of 8 grams per deciliter, indicating anemia. Her white cell count is remarkably high at 120 into 10 to the power 9 per liter, and her platelet count is quite low at 15 into 10 to the power 9 per liter. These findings set the stage for us to consider the diagnosis and classification of this condition. The combination of symptoms and lab results strongly suggests a hematological condition. Paying attention to the gum hypertrophy and bleeding, coupled with the high white cell count and low platelets, these are the key indicators that we will explore further in the next slide. We will now discuss how these clinical and laboratory findings align with the specific type of leukemia and what further investigations are necessary to confirm this diagnosis. Let's delve into the clinical presentation and laboratory findings that strongly indicate an acute myeloid leukemia diagnosis, particularly the monocytic subtype also known as FAB-M5. To start, the key indicators for this diagnosis include the patient's gum hypertrophy, bleeding tendencies, and a significantly elevated white blood cell count. These symptoms are classic signs of acute myeloid leukemia subtype FAB-M5. Gum hypertrophy or gingival infiltration in conjunction with bleeding diathesis is due to thrombocytopenia. This occurs because the leukemic cells often invade the gingival tissues, which is a hallmark of the monocytic lineage found in AML-M5. Now, let's focus on the elevated white blood cell count. This is not just any increase, it's a pronounced rise that aligns with the monocytic lineage, further confirming the suspicion of AML-M5. In summary, the combination of these clinical findings, gum infiltration, bleeding tendencies, and high WBC count, makes a compelling case for diagnosing and classifying this condition as acute myeloid leukemia, specifically the monocytic subtype. Next, we will explore the laboratory tests that confirm AML-M5 and delve into the specifics of the laboratory diagnosis. Let's delve into the laboratory diagnosis for confirming AML, specifically the monocytic subtype M5. First, we will consider the initial investigations: full blood count and peripheral blood smear. These are the frontline tests. Typically, they reveal anemia, thrombocytopenia, and leukocytosis. The peripheral blood smear is pivotal here. It helps us identify blasts, which are immature white blood cells. The presence of monoblasts or promonocytes is a strong indicator of AML. Next is coagulation profile. This test assesses for disseminated intravascular coagulation or DIC. It is a potential complication in acute leukemias and is crucial to detect early. These investigations provide essential insights into the condition and guide us towards a more definitive diagnosis. Remember, these tests lay the groundwork for understanding the patient's condition and pave the way for more specific diagnostic procedures, which we will be discussing in the next slide. When diagnosing AML, particularly the monocytic subtype, definitive diagnostic procedures are crucial. Let's start with the bone marrow aspiration and biopsy. This procedure is considered the gold standard for diagnosing AML. According to WHO classification, the presence of more than 20% blasts in the bone marrow confirms the diagnosis. It's important to note that the older FAB criteria required 30% blasts for a diagnosis. Now, moving on to cytochemistry, this involves the use of specific stains to identify cell types. In cases of monocytic leukemias like M5, stains such as myeloperoxidase MPO or Sudan black B may show weakly positive or even negative results. However, the non-specific esterase test, which use alpha-naphthyl butyrate esterase, is strongly positive in monocytic cells. And an interesting point here is that the non-specific esterase test can be inhibited by sodium fluoride, which helps in distinguishing M5 from other AML subtypes. These procedures not only confirm the diagnosis but also provide critical insights that guide effective treatment strategies for the patients. As we move into advanced classification and characterization of AML-M5, our focus shifts to two main techniques: immunophenotyping and cytogenetics. First, immunophenotyping through flow cytometry is crucial. This technique allows us to identify specific cell surface markers that are characteristics of AML-M5. Notably, these cells expresses monocytic markers such as CD14, CD64, CD11C, CD4 and CD11B, along with pan-myeloid markers like CD13 and CD33. This profiling helps us confirm the subtype and tailor treatment strategies effectively. Next, let's discuss cytogenetics and molecular studies. Karyotyping is a key test here, used to detect chromosomal abnormalities. For instance, the presence of the T911 translocation is often associated with acute myeloid leukemia M5. Detecting such genetic anomalies not only aids in diagnosis but can also provide prognostic information and influence the treatment decisions. Both immunophenotyping and cytogenetics are integral in providing a comprehensive understanding of the disease, allowing for a more precise and personalized approach to the treatment. Hope you understood the topic, and thank you.